My name is Karl Van Osten. I'm the Director of Orthopedic Trauma at North Mississippi Medical Center in Tupelo, Mississippi. This patient was a 28-year-old male involved in a motor vehicle accident, and he complained of left hip pain. He had no other significant injuries that needed to be addressed, and we were consulted. The sequence of events we're going to discuss will show us how we got from his preoperative film on the left to this postoperative film down here on the right. So injury film again, basically AP pelvis shows left hip fracture dislocation. And you can see the posterior wall or portion of the posterior wall component of this injury. So the CT scan confirmed essentially transverse posterior wall fracture pattern with a very comminuted posterior wall and some osteochondral fragments in his joint. One thing to mention here is this transverse component of this fracture is not significantly displaced. And I felt this would be a nice opportunity to try to utilize this novel implant in this situation, especially with a sort of a minimally displaced fracture, and felt it would be a good indication for a percutaneous type fixation of the anterior column in this particular injury pattern. So he was taken to the OR when he was stabilized. We placed him prone on a flat Jackson table and proceeded with a Coker-Langenbach approach. We used a large femoral distractor initially to distract his hip joint and remove all those osteochondral fragments in the joint and put them aside to later reconstruct the posterior wall. The transverse fracture, as mentioned, was fairly well aligned, especially after those fragments came out of his joint and his hip was reduced. The anterior column component was additionally reduced and compressed. I like to get it as anatomic as possible and compress it and hold it until the fixation apparatus is into the column. So there's a standard sort of angle jaw through the sciatic notch and standard location, compressing the anterior column component of the fracture. We then try to get our start point for this device, and you can see the guide wire in the obturator outlet view and the inlet view. One thing to note here particularly is that guide wire is not perfect as far as where it's aimed, especially on that obturator outlet view. And if one was doing a straight implant, it may be sort of difficult to, if that was the guide wire, and imagine you were trying to do a long 6.5 screw, it may be difficult to accept that trajectory and that start point to continue to get adequate fixation in this circumstance. So with that guide wire in place, as mentioned, if you look at that fluoroscopic image on the left, we're potentially not satisfied with that if we're using a straight implant, but this technique calls for a few centimeters of opening with a step drill or the opening reamer, if you will. And in this situation, obviously that was very adequate. The next thing is the cannula and the steerable guide wire. And as you can see in the second image, it's very easy to then manipulate this steerable guide wire and turn it with a T-handle to whatever direction is necessary to remain within the safe osseous pathway of the anterior column, as it has been described. And this guide wire is then scooched along in millimeter increments by tapping this T-handle. The guide wire is very thin and flexible and can kink if you're not careful. It'll choke up a little bit with that T-handle, but it is otherwise very easy to turn it and manipulate it. And you can see as it progresses along over to that inlet view, showing its progression. So our final placement of the steerable guide wire for this case, and I felt this was fairly straightforward to do and was fairly easy, and was very happy with that. Was very interested to see that it was very curved, and that's obviously, I think, a good thing for this implant. Was very curious to see how that implant would follow the curve of this guide wire. So the reaming is next, and reaming is carried out over this steerable ball tip guide wire. And you can see the progression of this in several views. And the reaming was carried out in this particular circumstance up to the diameter of the body of the screw, which was 8 millimeters, while leaving the tip or the area where we were hoping the cancellous threads would get purchased, slightly under reamed, and making sure not to over ream that very end of the pathway here. So after the reaming was carried out, the implant was inserted. The reduction was maintained with that clamp until the implant was in its final position. And as I mentioned, it was kind of nice to see it go in that curved fashion. One thing to mention, obviously, is you'll see that guide wire is different. That's after the exchange tube is used. The exchange tube needs to be inserted fully. So you can pull the steerable ball tip guide wire out and put this straight wire in, but the straight wire will come out the very end of where you want it to come out, and not come out too early of the exchange tube and create its own new pathway, which would, I think, be just a sort of technical oversight. But this is the screw going in. Here's the screw, some other good fluoroscopic views of that screw as it's going in and then subsequently being locked. The obturator outlet, another inlet view. Here's the final position after it was locked using the torque handle and tensioning that internal wire and converting it to a rigid implant from a flexible implant. The clamp was removed, and then this curved implant that is stuffing the bony corridors, as was described by Dr. Meek, is in position and is now no longer flexible but stiff, and is completely filling this pathway and therefore maintaining this reduction which was obtained. So after the intercolumn CurvaFix screw was placed, we continued onward with the rest of the case and repairing the rest of the injury with some more standard posterior column plating, and then buttress plating and spring plating, et cetera, for repair of all the osteochondral fragments and repair of the posterior wall injury. So these are just our fluoroscopic images showing what we ended up with, basically AP and obturator outlet and an iliac oblique view. So here are the post-op films. Again, some standard views that would be obtained, showing, I think, a reasonable reduction in a good construct for this injury. Very pleased with the position of the CurvaFix screw in these images. We did use a 110 millimeter CurvaFix implant, and it really turned out, I think, just perfectly as it was seated and seated, almost ideally into the countersunk area of the ilium, and still had some purchase from the distal cancellous threads. So at 10 weeks, this patient came back to see us. He was doing very well. These were his images. He was weight bearing as tolerated at this point. He had been slightly non-compliant, which is, I think, obviously not great. I think he started weight bearing maybe around 5 or 6 weeks, and I may have waited a little bit longer with that comminuted posterior wall, but he was doing well. There were no issues at this point. He had full range of motion, no complaints, no pain, and was wondering why he would even need to come back again and see us. Some summary points for this case and my experience overall. This was the first case I actually did with this implant, and some things jumped out to me pretty quickly. It is a much more forgiving start point. I think we sort of discussed that during the case presentation. In fact, I think potentially a more eccentric or not perfect start point might end up being a very good thing with this particular type of implant. And as I've done some posterior pelvic ring cases, I've experimented with different start points that will allow the implant to actually curve more, as obviously we don't need to be straight on our pathway with this implant, and having it curve and stuff these osseous pathways and then become fixed, rigid, and locked is going to provide even more stability and fixation and holding power. The steerable guide wire does allow for some tactile feedback. I think it's nice. You can turn it with the T-handle and feel it scratching, quote unquote, along within the osseous pathway, as one of my scrub techs is very fond of saying. The tactile feedback rather is also very, I think, interesting because when reaming, it's almost like you're reaming a long bone. You can feel the chatter, quote unquote. And this to me was an interesting experience. Reaming an osseous pathway of the pelvis, and you can follow it on fluoroscopy, and you can feel the reamer chattering along that osseous pathway, and it does sort of give you that additional feedback that you're within that contained safe osseous pathway. The curved implant follows the curved bony corridor, which is obviously the idea. And then it stuffs that bony corridor, and then it's locked into place. And if one has a good reduction, and the implant is then curved and stuffed in and locked, it's in my opinion, a really nice way to maintain that reduction.